I'm Alice Miranda Olstein. I'm a healthcare reporter at Politico, and today we're talking to Representative Raul Ruiz, a California Democrat and the leader of the Congressional Hispanic Caucus for the Harvard Chan Studio series Public Health on the Brink. So, Representative Ruiz, throughout the pandemic, you've had one foot in Congress making policy and one foot on the ground working as a doctor in your own district, seeing the policies you've been part of creating in action. I would love to hear what's a moment that you think demonstrates sort of the best of the government response to the pandemic, and one moment that you think demonstrates one of the biggest failings.
Excellent. Well, first, it's good to be on this series as an alumnus of the Harvard Chan School of Public Health. It was a great academic experience, and I can tell all the students and faculty what I've learned at the School of Public Health, I've applied not only in Congress, but also in the field. And I wear three different hats when I do this work, and I combine them all at once, not only as a legislator through my experience at the Kennedy School, the Masters in Public Policy, as a public health expert in looking at big framework and pictures on population health, and then also as a medical provider, as an alumnus of the Harvard Medical School, as an emergency medicine physician that takes care of patients and hands-on. And I do believe that one of the successes of Congress and this administration has been the focus on equity and the ability that the administration had to prioritize and set a goal in the amount of resources that under-resourced and minority populations that have historically faced and currently faced disparities in the pandemic would receive. So the federal and retail pharmacy partnership program that President Biden initiated allowed us to bring hundreds of thousands, if not millions, of vaccines into rural or underserved urban poor communities where historically they haven't had access to vaccines. And we've seen it play out in the vaccination rates of Hispanics, which is unheard of, that there is no difference in terms of the rate of their population, the percentage of population versus the percentage of the population of Hispanics being or of Hispanics making up those that have been vaccinated. In fact, now I believe it's above 20% of the populations that have been vaccinated of Hispanics, and they only make up 18% of the population, which is the largest minority in our country. And I participated in that program by advocating as a member of Congress to the retail pharmacies and to the administration to move equity in policy and resources. And equity is a public health terminology, and it's not just for academics to gloat over a fancy term. It's actual policy. It means moving resources where they're needed the most. It's simple. It's how we take care of patients in the emergency department, taking care of the sickest patients first. And it's how we mobilize resources into a nation or a community or in disasters in making sure we take care of our vulnerable and those that are most at jeopardy of dying. And so this was a big success that I was able to participate as a legislature, educating the community and local systems on equity, and then vaccinating people with my own hands as a physician out in farm worker trailer parks, in the fields, in churches, in the most hard to reach communities in my own district. So that was a success. I think some of the failures could have been the lack of foresight in dealing with the pandemic early on under the Trump administration, and the way politics influenced the distrust in the scientists, in the public health experts, and now how conspiracy theories became dogma. It was very difficult to really sound the alarm as a public health expert in knowing the epidemiological rates and explaining R naught, the rate of how many people a person who is infected would infect in others in the community, which gives us a sense of the rate of how fast this is spreading through the community. Knowing the R naught in the initial studies and extrapolating that for larger populations really was concerning, and being able to express it that we need to act much sooner to prevent that from happening was very difficult and very disappointing. Politicians in Congress, especially on the Republican side, were one, skeptical, and two, wanted to take a wait and see approach to moving resources and acting. And a wait and see approach does not work in a pandemic, especially with R naughts of 2 to 4, as we were seeing initially, or even R naughts of higher than that amount, because by the time you wait and see, you're about 2 months behind, and you're going to have the momentum that is going to ravage the community. And so you always have to act aggressively beforehand. And that concept is still difficult for policymakers who focus on politics to understand.
And I think we're seeing a little bit of that now with the stalled out funding renewal for coronavirus programs, both in the United States and overseas. And, the idea that even though things are better at the moment, cases are down from where they were before, there's sort of a lack of foresight in terms of we need to prepare now for a potential future surge. How can we as a country get out of this boom and bust cycle of public health funding where Congress only puts out money and resources once an emergency is already underway?
Alice, the Secretary of Health and Human Services, my good friend and previous Congressional Hispanic Caucus member, Javier Becerra, and our physician and public health hero, Dr. Fauci, was in front of the Dem Caucus, specifically talking about the need for this funding. And I spoke as a physician and public health expert, talking about how the delays of this function is causing even worsening disparities and is the opposite of equity, because the first to die and the last to get care are vulnerable populations. And a delay in resources means that the more vulnerable will be the first to suffer from any lack of vaccines, tests, treatment, or support, even on the social determinants of health, like housing, food, nutrition, that our pandemic relief funds have provided in previous laws. And so it was a real important issue. There's two key things, Alice, that we need to focus on. Now I'm going to get a little wonky. So all the public health students out there can get all excited about what I'm about to say. First is that it's a flaw in the way that we calculate cost benefit analysis, and the Congressional Budget Office, when they start scoring these different laws, put together their number of how much this would save or how much it would cost. And in the political world, there's individuals who have really created this culture that if it costs so much, then we're against it, right? And one of the reasons why prevention is not valued is because cost savings in an action and an investment that we do now is not taken into consideration in that equation. So when you spend money in order to reduce morbidity, which we will then reduce mortality, reduce cost of care to individuals in the long term, especially in their older years, then you're actually saving money throughout a span of 20, 30 years. But we don't take those into account when we do our scoring. And we need to change that so that we can put public health prevention measures and weigh them and give them the significance that they have. The other reason is politics. People don't understand the importance of preventing a crisis. So let me give you a scenario. Us in the public health world will say, we need to spend the resources, make sure we have research development in terms of the medications and vaccines, make sure that we spend the money to do the outreach and educate the community to take precautions and measures in order to prevent the crisis that we know is coming, based on history, based on science, based on previous studies that we've done in the public health world. Then the opposition will say it's not going to happen. It's never going to happen, right? That's just baloney. It doesn't exist, and we shouldn't spend the resources. So then let's say we spend the resources and there is no crisis because we prevented it. Mm-hmm. The pandemic mortality rate didn't get as high as we initially predicted it would get because we intervened. Well, then the opposition would say, see, we told you it would never happen. It was a crisis that was made up. It never really spread as fast as you guys said it was going to spread. And it was because of our intervention. That's the public health dilemma in politics and policy. So we need to reinforce the understanding of science, scientific studies, modeling, and we need to make sure that we rebuild the trust in our public health experts and in science.
I mean, that I'm sure that would apply to things other than COVID as well. It's hard to say, we prevented, look at all these, foodborne illness outbreaks that didn't happen because of our work. Look at all these things that didn't happen. It's hard to sort of quantify that and make that case.
Yeah, exactly. And so, we start to see a big push from individuals who would rather not see government, not have protections for public and for the public health, and to allow corporations to produce whatever they want to produce without regard to the environment or the public's health, then what they want to do is they want to disseminate the agencies that are out to protect the people's health. And consumers, et cetera. It's what the Trump administration did. They just started firing from within and hiring people that were anti-environment to be, the director of the EPA, for example. And so when one of their reasons was, well, look, we haven't had these issues in the past. Well, it's because they've been either doing their job, and we know that we still have issues, and there's other things that needs to get done. So this is one of the biggest eye openers that I encountered as a physician and public health practitioner in the field, is how much politics is involved in policymaking. I came in, wide-eyed, young, scrappy, and hungry to make a difference, and wanted to apply the evidence-based medicine, evidence-based public health to policy, and wanted to really focus on evidence-based good practice policy, and create a whole system in my office that would look at the data and would see how I could come up with good, sound policy. And we still focus on that. There's also another consideration, which is the politics in the district, the politics, in the nation, the politics in Congress. And how do you navigate the politics to move your policy forward? And that's something I think public health students lack in their training in moving good public health policy pragmatically through Congress or state legislatures or local counties, and how to speak the language of politics to move those bills. And I think we have a great opportunity to change that, because the pandemic has taught us the importance of being able to apply our public health research and modeling and practice into actual policy through resources and protections for the public.
And even if you and your colleagues do manage to approve this 22 billion the administration is asking for to continue the testing, vaccination, treatment programs for COVID, that money itself is not going to last very long, and we'll need to get another installment in just a few months. How can we stop sort of going from patch to patch and have something more sustainable and reliable for public health?
Well, I think that there's mandatory spending, discretionary spending, there's advanced appropriations spending in order for us to deal with preparedness. We can foresee large issues and address them before they become a crisis in order to prevent them. And so though there's different methods of appropriations, but in all of this, Alice, again, it goes back to political will, because at the end of the day, you're going to need to pass it with the majority vote in the House, and you're going to need to pass it through the filibuster with 60 votes in the Senate. And right now that requires 10 Senate Republicans. And so the dynamics changes every Congress with a different makeup of who's in charge of the gavels in the majority party, and how much space you have with the majority party in the Senate in terms of how many more Democrats, for example, in the Senate, so that you can help move legislation forward. And all those considerations by these members of Congress are, includes the political aspects of this policy.
Again, about the politics, a lot of people were hoping or predicting that the pandemic would really change a lot of the way politicians think about healthcare more broadly. And a lot of advocates had hoped that COVID would sort of provide the shock to the system that the country would require to seriously consider some sort of Medicare for all or universal single payer coverage model, or, at the very least, a public insurance option, as the president promoted when he was running for office. But now, we're not even seeing a lot of serious talk about a public option, or even about smaller things like lowering the age of Medicare. What happened? Why didn't the pandemic spur this as people thought?
Well, I'll tell you what you have seen, Alice. And you have seen the importance of addressing the social determinants of health. In the American Rescue Plan, there was billions for housing. You have the child tax credit, which helped relieve the child poverty rates and cut it by more than half. You have the ideas that we move forward aggressively through the Build Back Better proposal that came out of the House, with childcare, extension of the child tax credit, in reducing the cost of the premiums, to expand eligibility in the Affordable Care Act exchange market for the insurance companies, and the proposal to reduce drug costs. And just today, we had a meeting on the bill that we're going to be voting on that would cap the cost of insulin for diabetes. So I do believe that there is opportunity to move forward aggressively, especially with a public health option. But Alice, here's a key point and a lesson learned about the debate on healthcare in our country. We've been really focusing on who's going to pay what, and which stakeholders are going to receive the cuts in reimbursements or get incentivized by seeing a higher reimbursement. what we're not talking about is the healthcare delivery model. And that is a big component to making sure that we achieve equity, that everybody has access to care. Right now, our country does really well at taking care of really sick patients in very expensive ways in tertiary large hospitals. What we don't do well is keeping healthy people healthy and promoting wellness in our country. And we have learned through this pandemic that you just can't fund a broken system that has resulted in disparities and in an unhealthy population and expect a different result. That in addition to making sure that people have access to care through affordable health insurance, affordable care, that nobody's denied the care that they need simply because they just can't afford it, that we also need to address the way that we deliver that care to communities. Otherwise, you're going to still see the same disparities. And what we've learned, especially during this pandemic, and those of us who worked in the field before, is if you take a community home-based approach with equity in mind, working with our technology, whether telemedicine or tech medicine through iPads or your phones, and partner that with community health workers or the promotora model in the Hispanic communities, working together with the system to deliver home and community-based public health in education, in basic checkups, in connecting technologically a person with providers, then you will have better access to care and better outcomes. Insurance companies, academic institutions, community health organizations, and hospitals have all researched the use of post-discharge case management with caseworkers, social workers, with home visitations, with nurse practitioners, and community health workers. And by far, it's consistent that if you continue to provide the case management, the education, the integration of an individual in their community with the system, then they have better outcomes, they're happier, and they cost less because they're healthier and they're not going to the emergency department or having to be readmitted right after discharge. And so this is a lesson learned how we can continue to use the telemedicine, but combined with the aggressive equity community outreach with community health workers in the field, and combine those two to provide good quality delivery of care for our most vulnerable population.
It sounds like what you're saying is you have seen a shift in a more of an acknowledgement of how other aspects of life, like childcare and nutrition and housing, feed into health. But what we aren't really seeing is, during the pandemic, we made testing and vaccinations free of charge to everyone, regardless of their insurance status or their employment status. But we aren't really seeing people say, hey, maybe more healthcare should be like that.
No, we are saying that. And there are folks that are saying that. But you do know, again, it goes back to the fact that we would need 10 Senate Republicans to vote for a bill that would allow us to make those changes. And so we have to be pragmatic in making sure that we get what we can under this scenario. And when the scenario changes, then we can get more.
You talked about how public health can, better communicate. I wanted to, circle back to that. At the beginning of the vaccine rollout, there was so much concern, and you were hearing from the ground in your district about communities of color being very, hesitant and distrustful for very understandable reasons of the medical system and of the government. But now we're seeing, white conservatives are the ones that are much more vaccine resistant. And wanted to hear your thoughts on how the government and the medical community can do better to reach them.
Alice, first, let me start off by saying that the whole minority hesitancy was overblown, and it was also a convenient political argument for those who did not want to spend the money on minority populations or to address the disparities and the equity by dismissing the problem and saying, well, they don't want it anyway. The vast majority, for example, of Hispanics, as demonstrated by not only a Kaiser study, but also by what happened in real life. Now that we're so many months, years into this pandemic, is that Hispanic populations and minority populations want to be protected. They want to be safe, and they want to keep their family safe from this deadly virus. The largest reason why they weren't getting vaccinated was because of the systemic barriers to access. And they're found in multiple intersections with the healthcare delivery system. First is the access to the vaccines that the local counties were distributing to large hospitals and physician practices. Well, those favored those who had doctors, those who had insurance, those who knew how to navigate and had the relationships within the healthcare world to get those vaccinations. Then the administration moved them into communities of color, rural, vulnerable, working poor areas through the retail pharmacy program. What you saw was a lot of the affluent individuals who were able to spend time at home, who had internet, were signing up, making their reservations, and driving to those underserved communities and getting the vaccines, right? They weren't checking zip codes. They weren't checking, risk factors or vulnerabilities. And so that is what you saw. So the way that they went around it then was to give vaccines to the FQHCs, which serve the Medicaid and the uninsured population. And they also gave vaccines to the nonprofits that worked in collaborative ways and taking them into the places of worship, places of work, and schools, and in the local poor communities. Taking the care to the people was a smart way, and is how we need to change care delivery, because people got vaccinated. They came out in droves and they got vaccinated. And so that's why it's so important that we reevaluate how we look at equity and the method in how we deliver the care. Now it is true that there's a large resistance in white populations, mostly Republican white men, who, for ideological reasons, political reasons, and their loyalty to the Trump administration, were against every public health measure that pretty much that came out, whether it's physical distancing, covering your mouth so that your droplets don't infect others, or getting vaccines. And there's a culture brewing with the QAnon movement of conspiracy theories and misinformation, disinformation that's out there. And unfortunately, that disinformation is intentional, and the disinformation is also targeted in Spanish-speaking communities. We've seen disinformation on the vaccines, on politics, penetrating Spanish radio, Spanish social media, and the Congressional Hispanic Caucus. We just held a field hearing out in Miami to address this, and we're going to be meeting with the heads of all the different social media companies and asking them some tough questions on their plan to crack down on this disinformation in Spanish and targeting the Hispanic communities as well.
Related to that, I've been hearing from experts who are looking at this problem that it's so hard to bring someone back when they've been marinating in all of this disinformation. And experts feel that, energy is best spent on preventing new people. It's sort of just like viruses, preventing new people from getting infected rather than trying to re-educate people who have already bought into some of these conspiracies. I mean, is that your sense as well, and your goal in working with the social media companies?
I think that as a physician, we don't give up on any patient, regardless of their hesitancy or whatnot. Like, you want to take care of everybody, and you want to make sure everybody has the information available to help protect themselves. When you're faced with limited resources and you need to make decisions on how to have the biggest impact in your efforts, then prevention and the persuadables are going to be key. At this point, I wouldn't discount anybody. The biggest influencers for these white Republican men are their white Republican wives, who aren't as set in on being against vaccines, who are getting vaccinated at a higher rate, and they are a partner in being able to persuade some holdouts. But at the same time, we do know that there is an enormous amount of population, okay, who still are approachable, who are still vulnerable, who still have not had the opportunity to get vaccinated, who have questions that have been answered, whether it's due to them not knowing how to navigate the information system. Many don't have computers, don't have internet. They don't know how to navigate the system as to know where to ask the question. They don't have access to their physicians, or they might not receive the information in a language that they truly understand. And so we need to overcome those barriers to bring them into the fold, to answer their questions, to make sure they feel comfortable. And we need to spend the resources to persuade them with PSAs and the community outreach programs in the grassroots levels to really continue this grassroots mobilization of taking care and education into the community where they live, in order to really get them the resources and the answers that they need. And so there is a large proportion still of the population that we still need to reach. And there's so many lessons learned in this system. One is the fragile physician shortage workforce crisis issue that we need to address. This is an alarm that we need to sound now, because 1/3 of our physicians are in retirement age, and there's high burnout and people are leaving the workforce. And this is an equity issue because the physician shortages are pronounced in underserved and minority populations. Two is the fact that our public health system has been created to address crisis and to prevent infections in the population, for example, and to respond to disasters. What we need is to create a public health system that will produce a healthy and productive population. We are one of the most unhealthiest industrialized nations in the world, and that leaves us vulnerable for any kind of pandemic or disasters. And so our public health system needs to have one purpose: to make sure that we improve the health of our population. And then we discussed the delivery system. We have to radically change that. And we also have to improve trust in science once again, so that when we do have a public health crisis, that it won't be as hard to change behavior so that we can save the most lives. And we have to, from moving forward, we have to see equity as policy. And incorporate policy in every bill to address equity, meaning resources go where they're needed the most.
I want to thank you, Representative Ruiz, so much for taking the time to talk to us about what's happening right now on Capitol Hill and some of these bigger, longer term discussions about what needs to change on the public health front. Really appreciate your insights, and it was great to get to talk to you today.